be presenting my grand rounds on asthma and pediatrics. I do apologize for letting you see the notes section. I just recorded the entire presentation. I could view myself on the side of the screen, but somehow that didn't capture with the presentation in the PowerPoint in presentation mode. So there you go. You've got my secrets. I've written a lot of this stuff out. So I'm going to review the pathophysiology, epidemiology, and risk factors of asthma. Then I'll discuss the typical clinical assessment findings of asthma, differential diagnoses for asthma, diagnostic tests, prevention, treatment options, patient and family education, best practices, and follow-up care for asthma. So let's get started. What is asthma? So asthma is a chronic condition with intermittent reversible airway obstruction in response to a trigger. The small airways in the lungs constrict in response to these triggers, causing difficulty breathing, shortness of breath, cough, chest tightness, and wheezing. On examination of the lung, you can see small muscle hyperplasia, hyperactivity, and inflammation. Asthma is classified in two different ways. One of them is by type of trigger or stimulus, and then the other is how often the asthma attacks occur. These two broad categories above, extrinsic asthma and intrinsic asthma, are based on the type of trigger involved in the activation of the disease process. Extrinsic triggers are generally allergens, and intrinsic triggers generally come from within the body. You can see examples of the different types above. I did find it interesting that extrinsic asthma is more common in children and intrinsic asthma is more common in adults. The frequency of asthma attacks is split up into 5 categories or classifications. The least severe classification is mild intermittent asthma, which has fewer or equal to 2 attacks a week, and each stage has more frequent symptoms. And this goes all the way up to the most severe classification, which is called severe persistent asthma. In this classification, the asthma attacks are continual during the day and frequent at night. The pathophysiology of extrinsic asthma starts when the body mounts an immune response with the first exposure to a trigger. This results in IgE production, the antibody that's associated with allergies. Mast cells carry around these IgE antibodies and release inflammatory cytokines when they are re-exposed to the asthma trigger. These cytokines open up the epithelial cells in the basement membrane, allowing additional IgEs to get to the vagus nerve. The stimulation of the vagus nerve by the IgE antibodies result in release of acetylcholine that causes bronchial constriction. The mast cells also release chemotaxins that attract neutrophils and eosinophils, leukotrienes, and prostaglandins that cause bronchoconstriction, dilation of the blood vessels that allows excess fluid into the tissues, and mucus production by the goblet cells. So the mast cell does all those 3 things. The direct contraction of the smooth muscle by acetylcholine or the prostaglandins, the direct contraction of smooth muscle by acetylcholine, the mucus from the goblet cells, and edema from blood vessel dilation all result in airway obstruction in the small airways. Continued activation of these immune pathways can lead to a medical emergency called status asthmaticus. Of note, additional allergens are not necessary for this process to continue. Over time, the airways of an asthma patient become thickened and scarred. The pathophysiology of intrinsic asthma is not well understood. So the above pathophysiology was primarily of extrinsic asthma. It's hypothesized that intrinsic asthma can be activated by infections, and the infections can activate the same immune pathways that I described in the extrinsic asthma, including leukotrienes primarily. Aspirin is one of the most important types of intrinsic asthma to understand. Aspirin works by blocking the cyclooxygenase pathway, and when the cyclooxygenase pathway is unbalanced, it can allow more leukotrienes to be activated, which will once again cause the dilation of the blood vessels and edema. The summary of pathophysiology of both types of asthma is that exposure to an allergen causes reversible airway constriction. This produces the characteristic cough, wheeze, and shortness of breath. So So this next slide is on the epidemiology of asthma. And the CDC has a lot of great information on the epidemiology of asthma, including these two tables. As you can see, approximately 10% of the population has asthma, and the prevalence among children and adults is the same. This indicates that asthma is usually diagnosed in childhood and maintained through adulthood. Of note, Blacks have the highest percentage of all the races included in this study and are more likely to die from an asthma attack. Approximately 4,000 people a year die of an asthma attack in the United States, and then 7,000 additional people die with asthma listed as a contributing factor to their death. Risk factors for asthma include genetics, gender. I put genetics first because it's believed that there's a gene-environmental interaction that causes asthma. For gender, there are more males who are asthmatic prior to puberty, and then after puberty there are more females. I put Black race down as there's a higher incidence, so you'd be more at risk being of African descent. If you have a lot of allergies or allergic conditions like eczema, you have an increased risk for asthma. Mother's nutrition and weight has a lot of hypothesized risk factors and some that are known. So if a mother is obese during pregnancy, her baby does have an increased risk of having asthma. And then ironically, the risk is decreased if she eats peanuts or milk. Now, those are the only two that are shown to have a relationship, though a lot of others are proposed. Now, there's a linear relationship between exposure to allergens of house mites and sensitization to the allergen. However, the studies on allergens to pets has been conflicting, with some studies showing sensitization to the allergens and others showing desensitization. The effect of an out-of-balance microbiome is a hot topic. It's proposed to be a risk factor, and it may be a risk factor, but the Global Initiative for Asthma, or GINA, they point out that a meta-analysis wasn't able to show that cause and effect. And additionally, they looked at a study where probiotics were given, and there was no decrease in risk of developing asthma. Exposure to certain respiratory pathogens, pollution, and smoke are all associated with higher risks of asthma. Clinical assessment and typical findings. I've listed them here: chest tightness, cough, wheezing, shortness of breath, elevated heart rate, and anxiety. Symptoms are typically worse in the early in the morning and late at night. They vary or are intermittent, and they are triggered by certain stimuli, frequently allergens. The chest tightness can be described as pressure or pain and usually happens during an acute attack. However, in some instances, it can be the only asthma symptom present. 91% of asthmatics who present to the ER admit to some chest tightness. The sensation of tightness is likely resulting from bronchoconstriction, and the bronchoconstriction is caused by the vagal stimulation of ACH and the leukotrienes that we discussed on the pathophysiology slide. Cough may be the only sign of asthma as well. If this is the case, it is called cough variant asthma. The cough is a dry, it's non-productive, usually happens at night or in the early morning. Cough variant asthma is a common presentation in children and can progress to asthma with wheezing as they age. Patients with exercise-induced asthma frequently have a cough-predominant presentation. Wheezing can happen during inspiration or inspiration. Stereotypically, it is with expiration. So when the wheezing occurs just during expiration, it indicates a milder asthma obstruction. If the wheezing is present during both inspiration and expiration, it suggests more severe airway narrowing, as in a severe acute attack. The shortness of breath is a classic assessment finding and is related to some of the symptoms, the clinical assessment findings I listed above, and some of these next ones. So elevated heart rate, it's common during an asthma attack in response to the lower blood oxygen levels. It's a compensatory measure to try to get enough oxygen to the body. Anxiety is common due to the profound shortness of breath and decreasing oxygen levels during an attack, but should not be present between attacks. Differential diagnoses for asthma in infants and children is very, very long. The CDC and Agency for Toxic Substances and Disease Registry, or ATSDR, group the differential options into those that affect the upper airway, small or large airways, and other causes. I've included a portion of their table above for your review, but I'm going to focus in more detail on 3 specific differentials on the next few slides. Of note, in my discussion section, one of the questions is if you wanted to discuss about one of the other differentials. So here are some ideas for that later discussion if you'd like. So the first differential diagnosis for asthma that I'm going to review is gastroesophageal reflux. This condition is common in patients with and without asthma, so it should always be on the differential for patients with clinical assessment findings of asthma. Notably, the symptom of chest tightness, pain, and cough overlap exactly with the asthma symptoms. Gastroesophageal reflux is also a potential trigger for the intrinsic asthma subtype. Gastroesophageal reflux is often associated with severe or difficult to treat asthma, so it still should be considered for patients with known extrinsic triggers such as pollen or dust. The mechanism of action of the gastroesophageal reflux causing asthma-like symptoms is thought to either be the activation of the vagal reflexes that causes bronchoconstriction or inflammatory responses due to microaspiration. Treatment with a proton pump inhibitor can rule out asthma or diagnose gastroesophageal reflux as an intrinsic trigger for the patient's asthma. The second diagnosis I'm going to review is a foreign body in the trachea. Foreign bodies can partially obstruct the trachea or the bronchus and cause airway distress that resembles asthma. The X-ray included here is of an adolescent who had aspirated a blowgun dart and presented with cough and wheeze. Assessment findings that help differentiate asthma from an aspiration is the duration of symptoms, whether aspiration of an object is known, and lack of history of similar symptoms. However, in our younger pediatric patients, it may not be known that an object was aspirated, so careful assessment is necessary. The third differential, or this next case, is similar to the foreign body case, but it mimics asthma a little more closely due to a slower, more chronic progression. In this case, a 28-year-old girl had persistent symptoms of a cough and wheeze, unresponsive to standard asthma therapy. Imaging showed a cystic mass in the middle mediastinum that was compressing the trachea and left main bronchus. Fortunately, the asthma-like symptoms resolved with the excision of the cyst. Diagnostic studies and labs for asthma. The gold standard for diagnosis of asthma is with spirometry. Spirometry is a type of pulmonary function test that documents reversible expiratory airway obstruction in patients with asthma. Spirometry is done by forcibly exhaling as fast as you can over 1 second into a device that can measure the airflow. This measurement is called the FEV1 and is normal if greater than 90% in pediatric patients. Of note, this is different than adults. In adults, it is normal if greater than 80%. Since asthma only causes obstruction intermittently, the obstruction is not always present when the testing is done, so the FEV1 looks normal. A metacholine challenge is a way to irritate the airway in the lab in a similar way to asthma triggers so that the obstruction can be measured. This can also be done with exercise, as it also irritates the airway in some patients. After measuring the obstruction caused by the metacholine or exercise challenge, a bronchodilator can be given to show that the obstruction resolves. Something that I did not include in my slide here, but I also read about was less for diagnosing, but more for monitoring some types of asthma, and that is checking for eosinophil levels. Prevention of asthma. According to the Global Initiative for Asthma, or GINA, prevention of asthma is based on addressing some of the known risk factors for asthma. However, it's unclear how effective these strategies are, hence the 3 big question marks I put on this slide. GINA suggests the following as primary prevention measures: avoiding tobacco in utero and for the first year of life, avoiding acetaminophen and broad-spectrum antibiotics for the first year of life, and avoiding pollution as possible. GINA advocates healthy maternal weight, vaginal delivery, breastfeeding, and promoting a positive, supportive, stress-free environment for the pregnant mother and newborn baby. The hygiene hypothesis proposes that today's extra clean environment does not provide enough exposure to microbes. The interaction between our bodies and the microbes has a positive effect that decreases the rates of conditions with a hyperactive immune system like asthma. This is based on evidence that children with vaginal births who are exposed to vaginal microbes, children raised on farms or in rooms with lots of microbes, and families with at least 2 cats or dogs have lower rates of these hyperactive immune conditions. There's insufficient evidence or conflicting evidence about maternal diet, exposure to pets, and exposure to other allergens as primary prevention strategies. I did mention here that there's no evidence that links vaccinations to development of asthma, so avoiding vaccinations would not prevent asthma. I guess that's a little bit of a stretch, but I thought it was pretty interesting and wanted to include that here. So every patient with asthma should have a rescue medication. A rescue medication is a short-acting beta agonist. An example would be albuterol. These drugs cause bronchodilation and allow an asthmatic to breathe during an attack. Controller medications are used to prevent attacks. They are only used when the patient has significant risk factors for exacerbation or if they have frequent asthma attacks. The risk factors include low lung function, recent history of exacerbation that requires oral steroids, or a past history of exacerbation that requires an ICU admission. The frequency that necessitates controller medications include needing the rescue inhaler more than 2 times a week or at nighttime more than once a month. Inhaled corticosteroids are started at the low dose as a controller medication, and then as the frequency of attacks increase, so does the strength of inhaled corticosteroids. So it goes low, medium, and then high on those inhaled corticosteroids. If asthma attacks happen at least twice a week, a leukotriene receptor agonist, or LTRA, can be added, or theophylline can be given instead of or in addition to the inhaled corticosteroid. When asthma attacks happen daily, a medium or high dose inhaled corticosteroid is combined with a long-acting beta agonist or a LABA. The LABAs are always combined with a steroid due to increased risk of death if LABA is given without the inhaled corticosteroid. If you go back to the pathophysiology slide, you'll see how the medications above help patients with asthma at that molecular level. The steroids and LTRAs will decrease inflammation, and theophylline and the beta agonists cause bronchodilation, and both mechanisms of action improve breathing and reverse the airway obstruction. Of note, GINA, or the Global Initiative for Asthma, has several great tables with a stepwise approach to asthma by age group for controller medication choice. Many other organizations that treat asthma have similar tables. I suggest having a copy of one of these tables for each age group in your practice to refer to as you treat patients with asthma. Treatment routes for asthma. I briefly wanted to show you which medications for asthma are inhaled and which ones are oral. As you can see above, the mainstay of asthma treatment is inhaled, but some of the add-on asthma medications come in an oral form. There are some less commonly used medications like aluzumab that are given by injection. Now, not all of these medications are options for our little kiddos. Specifically, the LABAs and long-acting muscarinic antagonists are not indicated under the age of 12, and that aluzumab that I mentioned that's given by injection which is a type of immunotherapy, is not indicated for children under the age of 6. Non-pharmacological treatment for asthma. These are complementary to pharmacological treatment and cannot be the sole method of treatment. Medication is always necessary. Trigger avoidance and reducing stress are the only non-pharmacological treatments supported by GINA. However, other sources advocate the prevention techniques listed earlier as factors to also reduce the severity of existing asthma. Patient and family education on asthma. Trigger determination can be done through a diary of asthma attacks, combined with a list of what the patient encountered around that time. The patient and family can bring the diary into the office, and this will help the provider determine possible triggers. And as they avoid these triggers and track the frequency of attacks, they can hopefully decrease those. So education about trigger avoidance is an essential piece of patient-family education. Proper medication use and side effects should also be addressed. Difference between relievers and controllers needs to be emphasized. I think we've all had a lot of patients come in who are using their rescue inhaler 10 times a day, and when you ask them about their controller medication, they say that their rescue inhaler was taking care of it, and obviously that is not optimal based on the side effects of the reliever medications. Inhaler technique, including the use of a spacer, is important so that the patient can make sure to actually get the medication down deep into their lungs where they need it. Rinsing their mouth out after taking the inhaled corticosteroids is important so they don't get growth of candida. And then if the patient's using a nebulizer, additional information on keeping the device clean should be addressed, etc. Now, some patients don't have asthma attacks that often, so stressing the importance of carrying the rescue inhaler with them at all times is probably more important for those patients. Self-monitoring, which can include a peak flow measure for older children or their diary, is important so that as providers we can know how to titrate or down regulate their treatment as appropriate. We always want to make sure that our patients know how often to follow up with us. That could be signs that urgent care needs to be pursued or that they need to go to the emergency room. And I'm going to go into those details on a future slide. Every patient should have an asthma action plan so that they know when to pursue the emergency treatment, kind of related to that, the point above this. The plan is so individualized and it changes, so I suggest writing it down at each appointment and then asking the caregivers to use a teach-back method so that you can make sure that they actually understood the plan. You always want to review interventions to ensure or improve adherence. This should be tailored to the patient and family based on the assessment of the family's needs. For example, a low-income family may skip maintenance inhaled corticosteroids due to cost, or a divorced family may have a hard time keeping track of equipment or exacerbations as a child splits time at 2 households. Letting each family know that addressing concerns with you will help you troubleshoot the areas that they're struggling with. Best practices and optimal outcomes for asthma. Using clinical practice guidelines or CPGs when available leads to best practices and optimal outcomes in all areas within the medical field. The most recent CPG for asthma in the United States came out in 2007. I did not discuss this guideline in detail in this presentation as it's over 5 years old, but wanted to provide it to you for your reference. The Global Initiative for Asthma updated their guideline statement in 2008, so this should be used as it's the most current CPG available for asthma treatment. This guideline was used extensively in the previous slides, specifically on treatment, so refer to those slides for best practices. As promised, here is the section on follow-up care. After initial diagnosis and after starting a new medication, visits should be at 2 to 6 week intervals. An appointment should be made whenever asthma attacks increase in frequency or severity, with any asthma exacerbation and after exacerbations that require hospitalization. Patients should be seen every 1 to 6 months for maintenance and every 3 months when step-down therapy is anticipated. All right, here are the discussion question options. I'd be curious to know if you learned anything new about pediatric asthma in this presentation, and if this presentation will change your practice as a future FNP. How would you review the patient and family education for pediatric asthma? Are there any resources that you would give them, or how would you phrase things? Is there another differential diagnosis for pediatric asthma that you would like to explain to the class? Is there an app or a website you use in practice that helps you with the diagnosis, assessment, treatment, or education of patients with asthma? Or are there apps that you actually suggest for the patients and family to use so that they can track their asthma, etc.? The next couple of slides are all of the resources that I used. And I will just go over these so that you can see them. I think I missed that one. There we go. All right, well, thank you so much for watching my presentation. I hope that you learned something, and I look forward to that discussion.